The next section is about the faculty research presentation. We have three interesting research from our faculty. Let's begin with the first one from Assistant Professor Gulapat Junsamli from Chakri Narubodin Medical Institute, Mahidol University, in the topic of the correlation between shape, closed femoral stem design, and bone cement implantation syndrome in orthopedic elderly femoral neck fracture undergoing cemented hip arthroplasty, a retrospective case control study in 128 patients.
Good morning, everyone. My study is about the risk factor associated with bone cement implantation syndrome, wherein we have discovered a new possible surgical risk factor. The bone cement implantation syndrome, or BCIS, represents a fatal complication arise from cemented hip replacement procedure, particularly in elderly patients. Most of the evidence point to an increase in intermediary pressure as the cause of BCIS. The elevated intermediary pressure that generates during cementation, pressurization, and prosthesis insertion can lead to an infiltration of the fat marrow, air bubble, or even metallic bone itself into the vascular system, resulting in embolism. The pulmonary vascular system is the most common site of occlusion. Mild to moderate occlusion cause various degree of desaturation, while severe occlusion leads to right-side heart failure or even the cardiac arrest. Nowadays, there are a lot of discovered risk factors found to be associated with BCIS, such as the patient with old age, underlying of cardiovascular or pulmonary compromise, excessive pressurization of the femoral stem, and the use of cemented femoral long stem. Considering the implant factor, there are two types of primary cemented stem: the shape closed femoral stem type and the false closed femoral stem. Considering the shape closed femoral stem type, where the stem geometry is large and fill up most of the proximal femur, it could generate greater amount of intermediary pressure than the smaller tapered stem design ones. So the question of this study is whether the type of stem influence the incidence of BCIS or not. The aim of this study is to identify the correlation between cemented femoral stem design and other perioperative risk factor of BCIS, and the secondary outcome including the investigation of the prevalence and the impact on the patient outcome of BCIS in geriatric femoral neck fracture patients. This study is a single-center retrospective review conducted between January 2016 to April 2020. The inclusion criteria including the patient age above 75, diagnosis with the acute femoral neck fracture from low energy trauma, and receiving cemented hip replacement for the femoral stem, and negative DVT screening with Doppler ultrasound preoperatively. Exclusion criteria including multiple fracture, revision surgery, and pathological fracture other than osteoporosis. The BCIS diagnosis is made by the separate agreement of the two reviewers, the senior soma surgeon and the experienced anesthesiologist, who are not involved in the data analysis. During the cementation process, if there are hypoxemia, hypotension, cardiac arrhythmia, or cardiac event that happen during the cementation process, then the diagnosis of BCIS is made. Then the BCIS was then classified into grade 1, 2, and 3 according to the Donaldson classification. In this study, BCIS grade 2 and 3 are considered as severe BCIS group. The Metcalfe software version 15.8 were used for statistic analysis. And for comparing risk factor, we use univariate and multivariate logistic regression analysis. There were 150 patients with osteoporotic femoral neck fracture who underwent cemented femoral hip replacement during study period. The 22 patients were excluded. The remaining 128 patients were classified as no BCS and BCS grade 1 for 120 patients, and 8 patients were classified into the severe BCS group. Result, there were 40 patients operate with the shaved cross femoral stem type and 88 patients operate with the false cross femoral stem type. There were no significantly different observed in terms of demographic data between both groups. In the univariate analysis for severe BCS group, the factors that have a p-value less than 1.0 were included next into multivariate analysis, which are including the age above 90, underlying of cardiac arrhythmia, and P-injury Parker mobility score less than 4, delay time to surgery more than 5 days, and the use of the shaved cross femoral stem. Following the calculation of the multivariate logistic regression analysis, the significantly independent predictive factor for severe BCS group, including the patient who have age above 90, the poor mobility injury score pre-operatively, and receiving the shaved cross femoral stem type, which have an odds ratio of 19.1. Overall incidence of the BCS in this study was 32%, for grade 1 26%, grade 2 6%, and grade 3 2%, which is consistent with the finding from the previous study. The major perioperative complication was significantly higher in the severe BCS group. However, there was no significant difference in terms of in-hospital and 1-year mortality rate. Considering the 8 patients in the severe BCS group, 1 patient experienced intraoperative cardiac arrest immediately during cementation, and 3 patients has cardiac arrhythmia and significantly BP drop during cementation, and all the 3 patients progressed to cardiac arrest within 12 to 72 hours after surgery. This finding indicates that BCS is an important and potentially fatal complication of the cemented hip replacement, especially in the elderly patient. Conclusion, the patient who have age above 90 with poor mobility score P-injury and receiving the shaved cross femoral stem type are the strong significant risk factor for severe BCS. The patient with those risks should be identified and strictly follow the guideline for reduce the BCS and prefer to use the false cross femoral stem type. Limitation, this study is a retrospective study in nature. The sample size was relatively small, so it could not detect other possible risk factors. Thank you.
Thank you, Dr. Gulapat, for the excellent talks.